everyone, I'm Meghali, as you all know, a second-year resident here at Cottage, and today for my Mythbusters we'll be talking about whether IV Levothyroxine improves organ viability in neurologically deceased donors. So to start off, I thought it'd be helpful to just briefly review some of the physiology that occurs after brain death. And so usually starts off with a catecholamine storm that does eventually dissipate and leads to low catecholamine states. And we also concurrently see a hormonal deficiency where patients will start to develop low vasopressin levels, thyroid dysfunction, which ultimately leads to lower thyroid levels, low insulin levels, as well as low cortisol levels. And in parallel to this, there is also cerebral systemic inflammation as well. But hormonal deficiency can exacerbate hemodynamic instability, and it can also lead to metabolic failure, and this can have negative effects on potential organ donors. And so this physiology is actually what forms the basis of the reasoning behind thyroid hormone supplementation. And it's specifically why it was used after brain death was declared in patients historically to support the hemodynamically unstable, neurologically deceased donors. And so we're going to walk through studies that date back as far as the 1980s that were rooted in this reasoning. So I also wanted to discuss thyroid hormone, its physiology, and particularly how it relates to cardiovascular hemodynamics. So the figure on the left here is showing the various interactions between thyroid hormones and the cardiovascular system, and we can see that thyroid hormone can influence heart rate, heart rhythm. It can also influence myocardial contraction and influence the risk of coronary artery disease in patients. It can influence the vasculature via regulation of blood pressure through smooth muscle tone and endothelial function. And it can also have direct effects on cardiovascular risk factors through regulation of lipid metabolism as well as modulation of inflammatory pathways as well. So specifically when looking at hypothyroidism and heart failure, we know that together patients who have both of these conditions can have myocardial dysfunction, which can lead to reduced cardiac output at baseline, but that can also trigger increased sympathetic activity, lead to peripheral and systemic vasoconstriction, and that can lead to an increase in venous return, increase the preload, and increase the workload on the heart as a whole. But with reduced cardiac output states, we also have activation of the RAS system, and that can reduce renal blood flow, reduce GFRs, and it can also increase renal and sodium retention, which can contribute to an overall increased venous return, increased preload, and more work on the heart. So this is something we see more typically in hypothyroid states, but the figure on the right is actually showing us what short-term hyperthyroidism can cause. And so short-term hyperthyroidism, as a summary of that figure, can essentially induce positive cardiovascular changes by improving left ventricular systolic function and enhancing left ventricular relaxation as well. And at the bottom here, we can see that ultimately stroke volume and heart rate both increase, leading to an increase in the cardiac output. So we'll go ahead and start by looking at the studies that were initially done to explore the effects of IV thyroid hormone in low cardiac output patients. And so the first study we'll talk about was done in 1989, and this was done in patients who had recently undergone a cardioplegic arrest or cardiopulmonary bypass. So they trialed giving IV levothyroxine to 10 patients who underwent open heart surgery, and 5 of these patients had difficulties in being weaned from cardiopulmonary bypass, and 5 of them had poor myocardial function despite being on intra-aortic balloon pumps and vasopressors. And so the researchers' results are actually outlined in this table below, where they looked at certain hemodynamic parameters, and they found that the MAP and the heart rate was increased post-op in the patients who received IV levothyroxine, and that there was actually lowering of the left atrial pressure and the central venous pressure in these patients. They also noted that there was successful weaning of cardiopulmonary bypass in all 5 patients who had trouble being weaned off in the first place, and that intra-aortic balloon pumps were no longer essential within 3 hours in about 2 of the 5 patients who had that trouble. So they concluded that ultimately less inotropic support was required in these patients due to administration of the levothyroxine, and they found these changes to be significant at a p-value of less than 0.001. So in 1996 then, they looked at the effects of T3 on hemodynamic status and cardiac function in heart donors. And here they had 37 neurologically diseased patients who were randomly and blindly given IV boluses of either a placebo, which was saline, or a T3. And that the way that they measured cardiac function here was to look at fractional area change on a transesophageal echo. And the fractional area change is equal to the chamber area in diastole minus the chamber area in systole. And this actually correlates very well with ejection fraction calculations. And so they actually didn't find any significant difference in FAC with T3 administration versus placebo. And the FAC was also unchanged in patients who already had impaired LV function as well. So they concluded that there was no significant improvement in hemodynamic status and myocardial function in these neurologically diseased patients. And they also commented on euthyroid sick syndrome, which we know to be common in our critically ill patients, as not being the main determinant of myocardial dysfunction in these patients. So moving on to a study that was published in JAMA in 2001. So again, they were looking at the role of thyroid hormone in the administration of potential organ donors. And so they took 19 hemodynamically unstable, neurologically diseased patients with traumatic and non-traumatic lesions. And all of these patients were resuscitated for organ preservation with fluids, inotropic agents, and vasopressors, specifically epinephrine and/or dopamine. And if, despite these measures, patients were still unstable, they were given 1 amp of 50% dextrose, 2 grams methylprednisolone, 20 units of IV insulin, or a 20 microgram push of IV levothyroxine followed by an infusion of 10 mics per hour. And so they collected hemodynamic data hourly before and after administration. And so the figures on the right here are actually demonstrating the results and conclusions of the study overall. So the graph on top is showing us the influence of levothyroxine on vasopressor requirements with respect to time. And in the context of the study, 11 out of 19 patients actually responded with decreased vasopressor requirements within the first 2 hours of levothyroxine administration. And by 4 hours, all patients had demonstrated some kind of decrease in their vasopressor requirements. The table at the bottom is comparing the hemodynamic profile before and after administration of levothyroxine. And we can see here, based on the p-values, that there is a statistically significant decrease in vasopressor support after administration of levothyroxine, and all patients had reduction in vasopressor requirements at the end of the study. And so they concluded that there was significant clinical benefit in giving patients IV levothyroxine after they were declared as neurologically diseased. So before we chat about this slide, I wanted to preface this by saying that between 2001 and 2015, there were multiple studies that were published regarding the efficacy of thyroid hormone supplementation in this group of patients. And I would say there were probably half the studies that continued to find clinical and statistical significance in providing this hormone therapy to these patients, but there were also just as many studies that showed that there wasn't actually any proven benefit and proven improvement in these patients. So in 2015, the Society of Critical Care Medicine released their formal recommendations regarding thyroid replacement therapy, and they stated that either alone or as part of a combination hormone therapy with IV vasopressin, corticosteroids, and insulin, that thyroid replacement therapy should be considered in these hemodynamically unstable donors or for potential cardiac donors with an EF of less than 45%. And so while this was their formal recommendation in 2015, we're going to walk through some studies now that have been published since these guidelines were published that have consistently shown that there actually hasn't been any proven or clinical benefit in the administration of thyroid hormone to these patients. So the first one we'll talk about is one that was published in 2020 by the Journal of Heart and Lung Transplantation. And this was actually done through the International Society for Heart and Lung Transplantation Registry, and so that's why they actually had such a large sample size. So they had a sample of about 23,000 adult heart transplant recipients that were looked at from 2006 to 2016. And they saw that in this sample size, about 15,821 received thyroid hormone supplementation and 7,181 did not. And the primary outcome that they looked at in this study was early graft loss. So early graft loss was defined as death or retransplant because of graft failure within 48 hours of initial transplant. And the secondary outcomes were looking at 30-day and 1-year mortality amongst organ recipients, recipient freedom from cardiac allograft vasculopathies, and then the incidence of treated acute rejection in recipients. And so I wanted to draw our attention to the graph on the right side, and this is interesting. It shows a frequency of donor thyroid hormone therapy use by year of transplant from 2006 to 2016. And what we can see here is that the overall usage did not really significantly change over the 10-year period. We started with about 60% in 2006 and came down to 64% it went up to in 2015, and then 61% in 2016. So I think this is a testament to the fact that there was inconclusive data even during this 10-year period that I mentioned from 2001 roughly to about 2010, where studies were coming out with contradictory evidence, and this is probably why there wasn't much change that we saw in favor of thyroid hormone supplementation in these patients. This is a table summarizing the outcomes of this study. So just looking at the table, we can see that donor thyroid hormone therapy was actually associated with an increased risk for early graft loss, and this was significant at a p-value of 0.01. And there's also been higher 30-day mortality associated in the patients who received hearts from a donor who had received thyroid hormone compared to those who did not, with a p-value of 0.02. And in general, when we look at the means, we can see that more patients with cardiac reoperation and permanent pacemaker placement were seen in the groups that had donor thyroid hormone given to their donors. This wasn't statistically significant, but I think it is something to point out. And though it wasn't statistically significant, the 1-year mortality was higher in the patients who received hearts from donor thyroid hormone recipients than non-donor thyroid hormone groups. So the next study I wanted to discuss was published in 2022, and this looked at the hemodynamic effects of levothyroxine and methylprednisolone in brain neurologically diseased potential organ donors. And so this looked at a study of about 199 adult donors, and they were randomized to receive high-dose levothyroxine, high-dose methylprednisolone, or both. And then there was also a control group that did not receive any hormonal therapy. And so the researchers in this study were trying to see the rates of reduction in vasopressor support in patients as a whole. And so what they used to quantify this was the vasoactive inotropic score, the VIS. And this is a descriptive tool that can quantify the amount of pharmacologic pressor support that a patient requires. And so this can be calculated using a weighted sum of all the administered vasoactive agents. So the summary of the equation is in this blue box here, and they found in their results that there was a reduction in VIS that was significantly greater in the methylprednisolone and combo groups, but significantly less in the levothyroxine group compared with controls. And in general, higher VIS scores can predict unfavorable outcomes. So this would point towards morbidity and mortality. So they ultimately concluded that high-dose methylprednisolone alone or in combination with levothyroxine led to significant reductions in vasopressor support, but when IV levothyroxine was used by itself, they didn't see any advantage that was offered in reducing vasopressor support. And so these are graphs that are showing the trends of the VIS score in two different groups. The first group in graph A is the sample size of 199, and then graph B is for a sample size of 184. 184 is actually the size of the cohort that was ultimately studied. They did lose a few patients due to attrition, and some patients had developed multi-organ failure very early on that was not salvageable. So we can see, though, that between the two graphs presented here, that the blue line represents the patients who received levothyroxine alone, and the red and the green dotted lines represent those who either had methylprednisolone alone or both together. And there is definitely a significant decline in VIS scores for the patients who had either methylprednisolone or the combo, but definitely not a significant reduction at all that we saw with patients who received levothyroxine by itself. So this brings me to the final study that is also the newest study that the New England Journal of Medicine recently published in November of 2023. And again, they were looking at the effects of IV levothyroxine in unstable neurologically diseased heart donors. And so they looked at patients from about 15 organ procurement centers in the US. Their sample size was about 838 patients who were hemodynamically unstable potential heart donors, and they had been declared as neurologically diseased within the last 24 hours. So half the group was randomly assigned to receive a 30 mics per hour infusion of IV levothyroxine versus the other group receiving placebo with saline for 12 hours. So the primary outcomes of this study were looking at transplantation, firstly, of the donor heart, graft survival at 30 days after transplantation, and then looking to see whether lungs or other organs were transplanted in the recipients. Secondary outcomes were looking at duration of vasopressor support, the donor ejection fraction, as well as the number of organs transplanted per donor. And so this slide is just showing us how they ultimately achieved their sample size. So they started out with almost 3,260 patients who were assessed for eligibility, and based on trial inclusion and exclusion criteria, they enrolled approximately 852, and then a few were lost because they never were able to start the study. So that's how they ended up with an N of 838. To discuss specifically what their inclusion criteria was, so patients had to be between the ages of 14 to 55 years of age. They also had to demonstrate hemodynamic instability, so they either received one or more inotropes or vasopressors after fluid resuscitation. And then exclusion criteria was including patients who had been declared as neurologically diseased, though over 24 hours prior. They had a history of coronary artery disease, they'd previously received T4, had a known history of valvular heart disease, prior sternotomy, or were HIV positive previously. So this is a summary of their findings in the study. And so we can see in the upper left graph that in both groups, just over half the hearts were transplanted without a significant in-group, between-group difference. So 54.9% in the levothyroxine arm versus 53.2% in the saline group. And this was not a significant difference with a p-value of 0.57. Among heart recipients, so if we look at graft survival at 30 days on the right here, we can see that graft survival at 30 days was actually very similar between the two groups as well. So 97.4% levothyroxine group and 95.5% in the saline group. And the table at the bottom left here is showing us the LVEF from the first echocardiogram. So this is actually more of a patient demographic data prior to the study was started, we can see then that the vast majority of patients who were in the study actually had a normal EF of greater than 50% at the start of the study. So more results from the study. So if we focus our attention on the table on the right, we can see that the median number of organs transplanted per donor was 4 in both groups. So that actually didn't differ much. And if we look at the table as well, about a few rows down, we can see that the proportion of donors who were weaned off vasopressor support by 12 hours was about 143 in the levothyroxine arm and 152 in the saline group. So there was actually no significant difference there. And then if we look at the median time to being weaned off vasopressors, period, the median hours to being weaned off was 22 hours versus 25 in the saline group. So again, not statistically significant there. And we can see that outlined in the graph in the top left as well, that there really wasn't a significant difference between the proportion continuing to receive vasopressors in the levothyroxine arm and the saline group. I also wanted to comment on what they found in terms of adverse events between the two groups. So severe hypertension and tachycardia was actually noted to be more common in the patients who received IV levothyroxine, and they had p-values that were significant for both. Though they did note that after they weaned off or did stop the levothyroxine infusion in these patients, that their adverse events of severe hypertension and tachycardia did improve. So what can we conclude from the studies that we talked about today? So in hemodynamically unstable and neurologically diseased patients, administration of IV levothyroxine alone with existing vasopressor support does not increase donor organ viability or the number of successfully transplanted organs. It can actually lead to early graft loss in recipients, and it's not been shown to increase cardiac function recovery in the donor patients. It does not reduce vasopressor support in donor patients, and it can lead to complications of adverse events like we just mentioned with severe hypertension and tachycardia in the donor patients. And it can also be seen to increase 30-day mortality in recipients as well. And I wanted to just also supplement this conclusion with a discussion of where we are currently with guidelines regarding thyroid hormone supplementation. So it was actually difficult to find anything that was fairly recent, especially after the Society of Critical Care Medicine's publication was released in 2015, but I looked at the Canadian Medical Association and their standpoint on this, and they actually suggest against the routine use of thyroid hormone supplementation in this population. And they believe that to be due to the fact that there is an absence of established benefit in RCTs recently comparing thyroid hormone versus no thyroid hormone. And then in 2023, the Trauma Surgery and Acute Care Journal released their recommendations, and they stated that in patients with devastating acute traumatic brain injuries, they should be managed potentially in the short term with hormone replacement therapy with either thyroid hormone, corticosteroids, insulin, or vasopressin, or a combination of those. But they don't actually specifically endorse whether IV levothyroxine by itself is beneficial and should be used on its own in these patients. So I think that there's still a lot of clarity that needs to be found in whether we should be using this by itself in addition to vasopressor support, or if there is actually just a benefit that's conferred with its use with other agents. And so I also wanted to quickly just discuss implicit bias that we still have in this realm of heart transplantation. Unfortunately, race still does play a role in whether Black male patients are being recommended for heart transplantation. An American Heart Association study in 2020 surveyed about 400 physician members of a national heart failure organization, and the members were blinded to the study, and they were asked to review clinical vignettes about Black and white male patients with advanced heart failure. And so when physicians were asked whether they would allocate heart transplantation or ventricular assist devices instead, they actually didn't find any objective significant bias at first, But then they did a focus group with about 44 physicians later to ask them to verbalize their thought process and to talk them through treatment scenarios. And this is where many of them verbalized that they felt that Black patients would be less adherent to medical therapy with less social support to be the reason for that. And so they were less likely to offer them transplantation to begin with. And I think this is definitely a reality that some of us may be familiar with, but a lot of us are not thinking about this. And I think that it's important for us to remember that we should be looking at each of our patients very individually with their individual set of circumstances, and that we should not be generalizing a certain individual to an overall group and their predicaments. So this is just another plug for us to check our bias whenever we can. But that's all I have for today. Thank you.
That's good. Any questions for Meghali? Or comments? I think the last two studies that Meghali presented were done in the last 2 years, and my guess is that the recommendations from those two last recommendations that you showed are probably going to be changed in the future.
Yeah.
Because those hadn't been published yet, and I think that based on those, which are probably the biggest, best randomized controlled trials, showed that there was not really a benefit to thyroxine.
I have a question for you.
For me?
Yeah, has this changed in the course of your own training as an ICU doctor from when you were in residency and fellowship to now?
You know, I was never really involved in transplant when I was a resident or fellow. And even now, even though we take care of a lot of these patients that we declare brain dead, once we declare them brain dead, if they're organ donors, the organ procurement agency takes over, so we never really are involved in these decisions either.
Why do you think it took so long for somebody to study steroids independently of thyroid hormone? I mean, that was my first question when you put up that first slide. Like, it was this all-you-measure-all, clearly. I mean, what explains that big gap and how many years between those studies?
I wondered the same thing because we've seen multiple studies show the efficacy of steroids in these patients, and I know that at Cottage we see that pretty frequently as well. I don't have an answer for that, unfortunately, but I did wonder that as I was reading about it, and was grateful that they finally did do a study to show that. Yeah.
And clearly, the original studies, I don't know why they were. You know, back then there were a lot of trials being done. A lot of things were being tested to try and treat vasopressor-dependent shock, including, people were giving combinations of dextrose, insulin, and potassium infusions and things like that. And I think that originally that it was kind of thought that, they have all these different hormonal changes, we'll just kind of replace them all. I don't know why it took so long, but that's kind of a common theme. Why does it take so long to look at these things? I don't know. And it's pretty clear that steroids do help not only for this, but also in, we use it in vasopressor-dependent septic shock. It's been shown to at least decrease vasopressor requirements, and maybe not necessarily outcome. Okay, well, I think it's time to vote. IV Levothyroxine improves organ viability in neurologically deceased transplant donors. How many think this is true? Well, it's confirmed. How many think it's plausible? How many think this is busted? Okay, that's pretty unanimous this time. All right, we're busted.